Can you tell us a little bit about the landscape of what is right now approved and when can we use them? Mainly talking about Elacestrant and Imlunestrant.
Yeah, so, for a long time, so you touched upon Fulvestrant, right? As you mentioned, there are different mutations, and Fulvestrant was thought for a long time to be the only active agent against ESR1 mutations, to varying successes. Fulvestrant is a SERD, so instead of decreasing the ligand, it would just destroy and remove the receptor altogether. I always tell my patients that if you have a door and that door is like letting in the estrogen, well, Fulvestrant will remove the door and put a drywall instead of it. And for a long time, that has been the standard of care for some of these patients. However, we know that it comes short. So over the past couple of years, a lot of effort has been put in trying to make it a better version of Fulvestrant, and while at it, trying to make it oral, so everybody knows that Fulvestrant being injected once a month is not the funnest thing. It's 2 injections, by the way, not 1, right? And patients are not really excited about it. So some of the early drugs that came into the market is Elacestrant. So that was one of the first oral selective estrogen receptor degraders, and Elacestrant was tested in the ELEGANT trial, EMERALD trial, I apologize. And the EMERALD trial looked at patients who had really progressed on the first line of endocrine therapy. And they initially were not specifically looking for ESR1 mutations. But over the course of the study, and as patients came in, they found that there are selective benefit they're seeing more in patients who have ESR1 mutation versus those who are wild type ESR1. And a study was comparing Elacestrant to Fulvestrant, and there was an improvement in progression-free survival. Hazard ratio, I believe it was a couple of months improvement on PFS. So Elacestrant got an FDA approval as a second line for patients who have an ESR1 mutation. Over the preceding few years, a lot more similar agents, oral SERDs, are starting to come into the market, and the one that took the second, I would say, spot after Elacestrant was Imlunestrant, which is another oral SERD that also has been tested in multiple different settings, including in the later line setting, patients who have progressed on AI and a CDK4/6, also all comers, not necessarily SER1 mutations. And then the pivotal trial with the EMBER-3 trial, in which they looked at patients who progressed on AI CDK4/6, and again, there was positive PFS signal in the EMBER-3 with the single agent Imlunestrant versus standard of care Fulvestrant, and that also got an FDA approval a couple of months ago. So this is the current landscape that we'll look at for ESR1 mutation. I would say, though, that this is a very specific situation. These are agents that are used at second-line setting after radiological progression will resist our familiar landscape, and if patients have to, end up harboring that ESR1 mutation. And I would say in that setting, some of the emerging data as well are trials similar, trials like the combination arm of EMBER-3, in which they actually added Abemaciclib to Imlunestrant, and that gave a further push to the progression-free survival against single agent. And then you have other agents, there are other trials as well that are testing other oral SERDs in that setting, either alone or in combination.
Yeah.